Hello, everybody. This is episode 56 of our podcast slash webcast, Artificial Intelligence and Cyber Surgery. My name is Dr. Andrew Gums, editor-in-chief of Artificial Intelligence Surgery. This is the official podcast for our journal. Our journal is the first journal dedicated exclusively to artificial intelligence and surgery. And I will let my co-host, Dr. Vincent Grasso, introduce our next guest.
Super. This is, episode 56, and we are the only surgical journal dedicated to all things AI. It's a great pleasure to have Daniele Piccolo on today, doctor. And thank you to Francesca Del Mar for the introduction. She's a professor at the Ca' Foscari Excellent Business University in Venice. Daniele, I understand that you're a neurosurgeon. You're also getting your PhD in Pavia, and you have an engineering background as well. Very interesting, you're a kindred spirit with Andrew and I. And please give us, some info about yourself for our audience, your background, what's your passion in technology, perhaps, why you became a neurosurgeon. Welcome to the podcast.
Thank you very much, Andrew and Vincent. So thank you for the opportunity to introduce myself. As you said, I'm a neurosurgeon with a background in engineering, and I'm currently pursuing a PhD in experimental medicine. And my journey from engineering to medicine has allowed me to view surgical challenges with maybe a different mindset, different view, more analytical, as you can say, respecting from my colleagues, other doctors, particularly when it comes to integrating new technologies in the field. So this is why I also choose to pursue neurosurgery as a specialty, because when I was a medical student, I was thinking what kind of specialties to pursue on, and I thought that maybe neurosurgery was one of the specialties that was more prone to innovation, and this was like I was lacking about the innovation part of medicine, not the traditional part. Of course, it's very important, but as both of you are very expert on this topic, we are here to try to innovate, to ameliorate the processes that were and the tools that we can use to help our patients. So this is why I choose neurosurgery. And of course, I'm passionate about how innovation can transform healthcare delivery and improve patient outcomes, both in surgery and out of surgery. So this is why I chose all my background here.
So what particular part of neurosurgery do you like the most, by the way?
Well, I'm very early in my career, so I'm just a junior neurosurgery. So I am lucky to be exposed to most of the field. So right now I really love to integrate in the oncology part, because I think it's also the most challenging, because the patient are the ones with the worst prognosis, so are the ones that can benefit the most from some amelioration in their opportunities, healthcare opportunities. So this is why the oncology part is, of course, one of my strong interests. But besides of that, also the functional part of neurosurgery, like the epilepsy surgery or the vagus nerve stimulation surgery, the pediatric surgery, is something that really interests me. Yeah.
So, I mean, do you think that oncology or patients with brain tumors are going to continually be operated on, or are things like, radiation therapy going to take over, or things like HIFU, or I don't know if you know histiosonics?
Yeah.
What do you think? What do you think about that?
Well, this may sound a little bit wrong, spoken from a neurosurgeon, but I hope that in the future, patient may not need surgery at all. I hope that all the oncology patient may benefit from just a pill, from the prevention, and from just a drug point of treatment. So this will be the optimal part for me, because we all know that the surgery is in part beneficial, but it comes with a lot of comorbidity for the patient. So everything that can be spared from the patient from the OR is beneficial for me. So I know that right now, every glioma patient must undergo to the operating theater to to underwent a tumor removal, but I hope that in the future the surgeon will just become a little less useful, and everything will be done in the laboratory to prevent the disease. Yeah.
Yeah, no, fantastic. That's what I always say about, you know, pancreatic cancer. Even when I was a kid, I was always hoping one day I could make my job obsolete. You know, the goal was always to one day be able to stop doing surgery or to retire, right? I thought that's why we went into medicine, so that
Yeah,
we
that's
could like
good. That's right. That's correct. This is
eliminate
something
our
that I
job.
always, this is always something that I always told my patient. Like I'm the first surgeon that I'm happy to not operate. I'm always happy to say, no,
Absolutely.
this is not necessary. Yeah.
Absolutely. That's like the whole concept. Because you had the benefit of growing up when minimally invasive surgery was fully matured. Vincent and I remember, you know, when there was open surgery and then minimally invasive surgery was the new kid on the block. And we were taught by, you know, a lot of surgeons who thought big incision, big surgeon. But luckily you were taught by people who didn't have that nonsense concept in their brain. So that's great to hear. And engineering, what interested you in engineering? Did you now Italy I know is a little different from America. It's not like you could do a bachelor in engineering. You have to go, medical school is separate. So how did you do
Yeah,
that?
that's right. Well, they're very different path. I was lucky to be a very prone guy to mathematics in my high school. So I went to the Olympics of mathematics here in Italy. In Italy, I was very prone to mathematics and physics and chemistry. So my professor during high school just told me that, Daniele, it would be a shame if if you don't pursue a degree in mathematics or in physics or in something very I don't know, engineering wise, like engineering like. So when I was young, I was just 17, 18. I was studying what would be my best future, and all of my friends, a lot of my friends were going to engineering school, but it was always I was always indecisive between engineering and medicine. So I was driven by my professor and my friends, and this is why I chose engineering the first part. And I loved engineering because it's very rigorous. You have to be very precise. You have to be very strict about this is how it's done. It's just one way. You don't you cannot paint out of the lines. It's very strict, and this is something that I really like. But during my engineering process, my engineering academic path, my father had some medical issue. Now it's well, fortunately now it's well. But he suffered from 2 heart infarct and underwent a triple bypass. And I remember talking to the doctors, and I really hate how I cannot understand what they were talking to me. So this was, I think, the key part that just pushed me finish engineering and start medical degree right now. This is the
I can completely relate to that. Now, there's something interesting that you said earlier, and I wonder if Vincent knows this, but before I elaborate, Daniele, is there a concept of nerd in Italy? Do you even know what the word means?
Yeah, I know. I know what the word means, but I don't think it's so spread this knowledge of the nerd type, the nerd guy, as it is in the US.
Yeah, because it's
Yeah,
very
of course.
interesting. I was surprised to find out, you know, there is no concept of nerd in
No, no,
in
that's
you
right.
know,
That's right.
the Italians. I mean, in Europe, really, this is really like an American phenomenon. The reason I was saying it is when you mentioned you went to the Math Olympics, like I remember, you know, when I was a kid, they would have called that the Nerd Olympics, which is so, you know, so mean and unnecessary. But then I was, you know, or I was reminded that you don't even have this concept, and I think it's important for, you know, the few listeners that we have from America to realize that this is really like American nonsense that doesn't even exist in other worlds, you know. So even though, you know, obviously some people now in America who consider themselves nerds are very, very proud of being a nerd, and so, you know, but I just always found that so interesting that it
I'm
did.
too. Yeah, yeah, I am
So
too. I'm too very proud.
Yeah, yeah. I love my nerd side, but anyway. So okay, interesting. And your interest, so you are a natural to be an AI neurosurgeon. You already have the, the engineering background. What AI were you exposed to during engineering?
Well, actually, not very much of it, but of course, all my engineering studies helped me to gain a background useful to get a grasp of the true value of the AI. Because right now there's a lot of talk about it, but I don't think that a lot of people understand the true value that AI can bring to the field, to every field, because there's a lot of talk about the generative AI. Of course, there's a lot of talk about the large language models, and we know all the big names that are out there. But to really get the maximum useful for the use of the AI, you have to, like Francesca said in her talk, you have to get your hand dirty with AI, and this is something that engineering has helped me to get my hand dirty with the AI. So right now I'm lucky enough to be able to code myself some algorithm, to code myself some try AI platform to help maybe prognose some patient or help to um, maybe help patient empowerment or help patient prospective care. Like this is something that I love to do.
So what is your PhD on? What is your thesis going to be?
My PhD is the main topic is experimental medicine, and the topic of my thesis is going to be the implementation of the AI in neurosurgery and experimental medicine. Right now, I'm also exploring the the use of quantum intelligence algorithm in prediction for the diseases. Of course, we are a lot early in the time frame of the quantum part of our lives, but right now we can use the quantum algorithm maybe for the feature selection to help us to understand what are the best predictors to understand what is the prognosis of a patient or a particular disease. Yeah.
So talk to me a little bit more about quantum analysis. I mean, are you talking about using a quantum computer, or do you need a quantum
Yeah,
computer to do quantum analysis, or
not
what?
really, not really, not really. Of course, it will be the optimal case, but they're very expensive. So you cannot have a quantum computer by yourself. You
Yeah.
can use some SDK where you're coding in just in some basic standard Python lines, and with those SDK, your algorithm is translated to a um, quantum-like algorithm and can be run on some servers like in AWS servers or D-Wave servers, or there are some providers out there that can give you some time in their server, in the quantum server, to run your algorithms and to see what the outcome is. So this is what I'm doing right now.
Because I often think, statistics, the way I was taught, were very frustrating. But as we know, AI is based on, a much more complex and multi-layered use of statistics. But I mean, Vincent, how would you, this is a tough question. How would you differentiate the concept of AI from how we used to do biostatistics? I mean, I know biostatistics now must be using AI for their analysis, but I'm actually not sure how statistics are done now. I've done propensity score matching relatively recently, and
Sure.
that's very, it looks like a very medieval way of doing statistics when we have all these complex algorithms. So how in your mind do you differentiate the two, or are they essentially the same thing?
No, I mean, this is so exciting because Daniele is a very dangerous guy. He's an engineer, mathematician, surgeon. I guess you're a programmer as well, Daniele. You're probably very good in Python and stuff, right? So what's really exciting question you asked, Andrew, is a guy like Daniele, he knows linear algebra, he knows calculus, he knows probability theory, he can do all that stuff, right? And the foundational statistical academic exercise you and I went through, and Daniele, I'm sure, they're kind of low level, straightforward calculations, right, on probability. But as you take advantage of libraries, et cetera, and higher level probability theorems and algorithms, you can extend with less data, take advantage of other data sets that normally wouldn't figure into those early calculations that we run, and have a richer environment. I know people that have died from glioblastoma, what we all do. And I have a very dear, close person that had a stage 2 rectal cancer basically obliterated with immunotherapy, right? He didn't have surgery yet. The thing is gone. So the likelihood, the statistical likelihood of a certain immunotherapy agent working on a certain tumor strain is a probability, right? Is a calculation. You need a lot of data to do that. And we're seeing the evolution of all this stuff. And Daniele's already talking about doing quantum assisted calculations on his data sets, right? So as we talked before, imagine having a department of surgery where somebody doesn't know engineering, doesn't know AI, doesn't know business, they just know surgery, right? You can't even move this conversation forward there.
Yeah, no, absolutely. Now, when you're doing your quantum analyses, are you using multi-omic data? Are you using radiomics, genomics? What data are you focused on? And is it mainly for your glioblastoma patients, or for your other pathologies?
Well, mostly it's radiomics and genomics, and of course the glioma patient is the core part of my job. But I've done also another project in epilepsy surgery where I have just demographic and electric data from the stimulations of the vagal nerve. So I have some data from the device, from the IPG itself. They can help us to predict how the patient is going to respond in the future to the stimulation of the vagal nerve. So this is all.
Explain to me more about this, because I obviously know what the vagal nerve, as far as I know it, mainly is as far as the vocal cords, diaphragm, and stomach. What are you stimulating the vagus nerve for?
Well, you stimulate the vagal nerve in a retrodromic way, so not an orthodromic way, not retrodromic way, to help to reduce the intensity of the crisis and the frequencies of the epileptic crisis in the patient.
Oh, so epilepsy.
And this
Okay.
yeah, and this is something that is not yet recognized well in the medical community, because it still talked about this as a palliative cure for the epilepsy. But we are seeing a lot of young patients with some very destructive crises, like they're having multi-crises per day, or the quality of the crisis is very heavy, like they're falling with their crisis, they're risking from a heavy injury with every crisis. And after the vagal nerve stimulation, we reduce the frequencies of the crisis in a couple of crises per month, or even the quality of the crisis is really changed. Like, for example, when they are going to, when they were falling before with the crisis, now they're just having some partial crisis with some dysesthesias, or just some feelings weird in their upper limbs or in their faces. And this is, of course, something that it's going to perceive it as a net improvement in their quality of life. So we think that's a very useful kind of surgery for the epilepsy patient.
So back when I used to practice in America, I actually had quite a few patients who I would give them medical marijuana prescriptions for epilepsy, and it worked phenomenally. Remind me, is medical marijuana legal in Italy, and do you have any experience on it with your epileptic patients?
Yeah, it is legally. I'm not a super expert. I'm not a neurologist in the epilepsy, so I don't know if there's some real usefulness in in epilepsy. What I can see here in Italy, the marijuana use is mostly for the pain control in oncology patient.
If you're gonna do
yeah.
epilepsy, I highly recommend, if possible, because as a surgeon, I was able to give medical marijuana to my patients. If you ever get the ability to, or any certificate that you need, I highly recommend that you look into that if you're going to deal with
All right.
epileptic patients, because it's incredible. You know what some patients report. You know, I'll leave it
Great.
at that. Yeah, no,
Thank
yeah,
you. Thank you for the
yeah,
insight.
definitely,
I'll look into that.
definitely. Yeah, interesting. So, do you also do any pathomic analysis? Do you look at, like, you know, the pathology slides, trying to look to see if that can give you any predictive value in your work?
Yeah, well, not actually in the slides itself, but of course, I'm working hand by hand with my pathology group. And of course, there's a lot of data with the molecular biology and the genome analysis. This is going to be really useful. We hope in the future to predict, not only to predict the course of the disease, but also to find some other ways to treat the patient for the second or third line. We all know that right now, for the glioma patient, that we have a standard line of treatment after the surgery, which is just one drug, the temozolomide, and after that, everything is just it's a little bit lost for the patient. So we are trying to investigate if there are some kind of new drugs or existing drugs that can be relocated for the use for the specific patient based on the specific gene alteration that the patient had.
We have a project that we're working on called Ergos, which stands for Artificial Intelligence, Radiomics, Genomics, Oncopathomics, and Surgeomics. And you know, we're interested in using multi-omics to create even more powerful you know, algorithms that can give us even better answers. But you know, some studies have reported that once you start doing that, once you start mixing omics, that if it's not done properly, you can actually make your algorithm less powerful. So that's why I'm wondering if you have any experience with that. Is you probably have, you know, you probably haven't combined more than 2 omics, but do you have any? But I could be wrong. That's why I'm asking you. Have you noticed any problems, or do you foresee any problems, or is it on the radar? Yeah.
No, of course, all this kind of there's a lot of problems for the implementation of artificial intelligence in medicine. Of course, we have a lot of ethical and legal considerations to consider, and like, for example, we have to think about the data privacy, informed consent, accountability in case of errors. So those are also a lot of things that we have to account for. Like, for example, in case of error of our algorithms, there's a lot of issues right there. We don't know who to blame. If he's in error, is the developer that developed the algorithm? The algorithm is the algorithm itself. Yeah, is it the data? Is me, the surgeon, that I'm using the algorithm? Who's involved here? So yeah, of course, combining different omics is going just to exponentiate the possibility of these kind of issues. Yeah.
So last question before I'm going to turn it over to Vincent. We are also developing the concept of surgeomics. We want to combine all of that data with intraoperative video data, you know, ultimately so that we can get real-time decision support. But in the meantime, for us, it's very easy to collect data laparoscopically, robotically, even with open surgery, but less commonly done. For your surgeries, do you have a problem recording your procedures? I mean, it's hard enough for you to see. Are you guys using microscopes? Are you using you know, are you able to record? I'm not sure what the visualization is.
Yeah,
you guys, but you don't really have minimally invasive resection of glioblastomas, do you?
No, not really, but we do some keyholes approach. So the craniotomy is very small. Of course, I will say that 95% of our work here in Italy, at least, is done by the microscope. So we don't have any problem to record the surgery, and also to have the ability to inject the microscope with some information from the outside. Like, for example, the new microscopes are able to implement augmented reality into the operating room. So this is something very useful. And yeah, I totally agree that it's a lot of data that can come out from the operating theater to be looked upon and to be searched for new insights, new way to help the patient, of course.
One more question I have for you. Sorry, Vincent. Do you use fluorescent dyes at all in your surgeries? And if so,
Yeah.
what indications?
Yeah, we usually do it for oncology to resect the maximum amount possible of the tumor, but also for the vascular surgeries where we just inject some androgenin green to see the vessels, and to see after a bypass or after the clipping of an aneurysm, we can see if all the vessels are patent, the ones that are not supposed to be clipped, of course. So yeah, we use this kind of
Will the tumor light
this
up?
kind of agent.
You have tumors.
Yeah, we do. Yeah.
Which tumors light up?
Usually it's the glioblastoma, the most aggressive ones. But there's a recent paper that is published in the literature that is going to a little bit undermine our sentences in this kind of thing, because actually what they showed us is not the tumor cell itself is going to be light up, but it's the monocyte. So it's like an inflammation part of the microenvironment in the tumor. So this is something very, very tricky, very interesting.
Nice. All right, Vincent, close it out for us.
What do we have? How much time do we have left there, Andrew?
We have 9 minutes and 45 seconds.
Just a quick question then from Daniele, because this is so exciting with his engineering background. I mean, the media has been presenting implants, right? Man-machine interfaces into people that they have locked-in syndrome, and they can be thinking thoughts, and they can be translated into a signal. I would imagine your world as a neurosurgeon is going to get very busy on the implant side of the equation rather than tumor resection side of the equation. Have you done any of that kind of surgery? Any experimental things happening at your hospital with those types of implants for research purposes, or is that in your roadmap moving forward?
Well, unfortunately not. I have not done yet any kind of implant surgery besides from the vagus nerve stimulation or DBS surgery. But of course, this is a very hot topic. This is, I think, also think that it's going to be a bright light in the future for not our field, because we're just going to do the small part of the implementation, but for the patients, of course. Yeah.
Sure.
You know,
Exciting.
actually, I'm thinking I want to stop sooner than later because I want to talk to Daniele offline. All right.
Okay, good. Well,
So
we'll wrap it up then. We're at episode 56, right? Episode 56 of our AI cybersurgery podcast. Daniele Piccolo, neurosurgeon, engineer, Olympian, mathematician, I guess during your Liceo days. Fantastic. And PhD in experimental medicine at Pavia. So we're looking forward to having you on again and talking about some of your more detailed neurosurgery work and how AI will fit into that ecosystem. Take care, everyone. Thank you.